Because I'm first up after lunch, I'm going to keep my part as brief as possible. Also because we have a group of people that speak with you that are fantastic, and I'd rather hear them than me. So let me walk through a little bit, kind of as an intro on developing partnerships with hospitals and academic institutions. I've had FQHCs say to me before, well, do I have to partner with a hospital? And the simple answer is yeah, because your residents have to have inpatient training, right? There's no model that allows you to say, yeah, we're just going to skip that hospital part. And academic institutions, do you have to partner with them? No. Okay, you don't. But when you look at recruiting, both of faculty and of residents, having an academic affiliation has value. And there are certain specialties that you do it, such as, say, internal medicine, you're really going to need that academic affiliation to recruit. Okay. Font is small. Why is the font so small? Anyway, it doesn't matter. So let's talk a little bit about this partnering word. Partnering versus anything else is really not partnering. Okay? Because most of the time, we don't see partnering. Partnering implies equal, right? Both sides or both groups or all entities seeing each other as equal with values that you each have that is different but helpful. And so that's one of the main things I want you guys to get is to know your values. And not only knowing your value, but knowing how this program is going to impact your organization. Okay? So what do you have to give to this relationship? Because you have a heck of a lot to give. And what are you going to need to make this work? It's a marriage. And not why I say it. It's a marriage because any resident you take in is with you for at least 3 years, depending on the program you set up. You're making no less than a 3-year commitment. We don't like to close residency programs because we impact these young people who have put their faith in you that you're going to see them through their training. And not seeing them through their training impacts their career because they now have to get waivers from their board because they haven't met certain requirements. It's not something we do lightly. So it's a marriage. And like any marriage, you need a prenup. Okay, let me phrase that. Hell, I've been divorced once. With marriage, sometimes it's good to have a prenup. I'll say it that way. Okay? With this marriage, I recommend a prenup, where you work through what happens if it falls apart and how we're going to work together. All right. It's also something that you set a long-term contract on. Okay. So with a partner, it's more than what you realize. I only did a partial list there, but there's you, there's the hospital, medical school. The program, residency program, somehow seems to think they're their own entity and have, and they do have a voice in all of this. So the program director. And then sometimes, as I mentioned earlier, you're going to have a faculty practice mixed in because we're in the state of California, we like to do things different. I had a client, I won't say what state because there are not enough residency programs in there to keep this anonymous, but residency program that was sponsored by an osteopathic institution. The hospital and a non-FQHC were the participating sites. There's a program director. and it got accredited, and then right after it got accredited, it lost its family medicine practice, its clinic, continuity clinic, and so they turned the FQHC to be the continuity clinic. So I go up to do the as we call in my hot mess categories of clients. So to deal with that, only to find that the program director felt like he reported to no one but himself. Sponsored by what's referred to as ODDIES, it's a nonprofit, sponsored by this group. There's 2 other entities involved, and he thinks he reports to no one. Clearly avoids who are the partners. Now, I won't go any more deeper into that story except to say trying to fix that balance of power is more than that console would say. Okay, so these are the partners. You've got to have conversations with all of them. Why? Because they're multiple masters. Each one of these partners has their own set of rules that they have to live with. They have their own boards. I should have listed boards on there too. That they have to get approval through, to be accountable. These masters don't all interact well. Okay? So as an example, in the world of family medicine, it no longer is a stated requirement in the regs, but it is in the application. There is a question. Does the family medicine program director have control of, I'm not quite getting the wording right here, but the educational activities in the clinic? Something along those lines. Now you tell me where precepting falls. Is it clinical or is it education? Okay? Yes. Yeah, it's both. So the program director has site control, but you are immediately going to say, well, wait a minute, HRSA requires us to be fully responsible for all clinical activities in our clinic. Okay, so this is an example of how the 2 masters don't interact well or don't intersect well, and you got to work those out. And honestly, the only way to work it out is in a contract through a lot of conversation. And it comes down to relationships. Okay? If you have HRSA, THC, GME funding, they have their own set of rules. CMS clearly has a lot of rules, and the hospitals have joint commission. So it's not a slam dunk to get all these partnerships. Back to knowing your value. So as I mentioned earlier, probably the thing that frustrates me most is when federally qualified health centers and Indian health services go into one of these conversations all ready to do whatever it takes to make this happen at their own expense. Okay? Your value. Okay. These organizations are looking to you because of your patient population. World Academic, we look at them as the curriculum. Okay? Huge. Huge. Where else can I get 14,000 visits like that to put in a residency program? I just took that number randomly. It's not a required number, but, 1969 number to have. Okay. You guys have the ability to go after NAP grants. Sorry, you guys don't. But you have funding streams that they don't have. Okay. Federal Tort Claims Act. Come on. That one's great, but you always have to have a gap policy too. Your rate. Okay, we talked about that earlier. 340B, National Health Service Corps, and then just a host of curriculum experiences that you can create. All of that is of huge value. All of that the program director is going to say, I want. The hospital is going to say, I want. Okay? So hold on to your value. Yeah.
I have a question. Some of what that you're mentioning with the new requirements, I can't remember how they described it about not just diversity, but what I think the term is.
Yes.
You mentioned it. Is there a way to recommend that we encapsulate that? Because I think we all do it. We just don't speak about it as simply as when we're referring value. Is that something?
I'm a huge social determinant of health lover, so for me it's like, yeah, of course. I think first it takes the program director recognizing and understanding that these are part of the new regs, okay? So, and that awareness is growing. And they've got to have no other easy way to do it. Now, one, it's also seeing how it ties to certain funding streams. Okay? So, I'm not on a social determinant of health for a minute, but cultural relevancy, strong brand. And if I had one thing I'd say, well, I'm not going to say it. I'm worried about whether there's any tracking after the fact of what we promised versus what we did. So I'm going to do X, Y, Z in cultural competency and cultural relevancy. Are you ever going to check to find out if I do?
Yes, we are. I think they look in front of the schools yesterday. Did they have any contact already?
None. Okay, good. So you write things like that into grants, and suddenly I have even more awareness of this is a group that understands this, can do this, has committed to doing this, has the bandwidth to do this. Yeah. You guys are light years ahead in team-based care, team-based model of care. Light years. You're ahead in electronic health records long before they hit any clinic. You're ahead in outpatient quality. And when I walk into an SQ, I just know that's all going to be there. Whereas when I walk into a place that is hot-fluorinated, I know it's not. So yes, it's a value. Is it enough for them to say, okay, we're not going to go with the clinic we control versus you guys? No. You've got to reach a common understanding amongst all of the parties. And that is memorialized in a legal agreement. It should be. Some folks don't want to. But that's a process of transparency, of educating each other about each other. I like to have a joint operating committee that continues on well after residents ever start. And then a regular true-up of the financial, so almost like a operational check-in of how we're doing financially, using a tool that is agreed upon up front and is appendix to your agreement. This is how we're doing the true-up. Nobody can change your mind after. You need to educate them on your requirements. I mentioned earlier, they don't know them. Or they think they get them, but they really don't. Okay? So, I don't know if I'd go pen by pen by pen, but I would go through, this is our board construct. This is why we have to have it that way. No, we cannot guarantee you a seat on the board. I have plenty of hospitals ask for that. Ask the F2HC. Well, we'll do this provided, we'll make this investment provided you guarantee us a seat on the board. No, you can't do that. So upfront educate about your requirements. Some key terms of agreements of these partnerships, I mentioned just a minute ago, have that financial tool that's an attachment. You guys want, if you're not sponsoring the program, have the right of first refusal on the program. Okay? If for any reason the medical school decided they no longer wanted a program, are you going to let it die? Or are you going to let the F2HC take it on? Okay. Wind down provisions. This is the prenup. How, if this program is going to close, how is it going to close? And nobody wants to think about that at the beginning, but it's really important. Because it forces you to have some crucial conversations amongst your partners, and you can flesh out some of their intent as well. I like 5-year terms minimum. I prefer 10. And I insist for family medicine on an 18-month termination clause. Shorter material for each. 18 months. Now, why 18 months? Kelly, why 18 months? The residents need to find a place to go afterwards. I think that's what it is. Yeah, it allows you to get your residents out without dramatically impacting their lives.
I didn't close the program.
Yeah, no, she hasn't closed the program. I'm taking on her. Okay, what'd I do? Okay. Yeah, so when you do the math and you look at if I close the program today and I don't match a class, well, here's a graduate, and when you walk it through, you're like, I can get everybody out. Okay, without too much negatively impacting their lives. Because even though anytime you're doing a wind down like that, you're still going to impact their lives. They're still going to have patients. Not the volume of patients they had before. The teachers aren't going to be quite as gung-ho about let's go teach, right? It's the program stuff. And then coterminous agreements. I've mentioned lots of agreements to you. Have them all expire on the same date, right? Otherwise, you're going to be sitting in a lease. It continues even though your program's been closed, as an example. Okay? So those are just some highlights of that. Without a doubt, you need a lawyer. Okay? I think that's my last. Well, because I can't get the slide to advance, I think that's my last one. Yeah, that works. Okay, so who is next on the agenda in this section? Is it you, John?
No.
I volunteer you, John. All right. There you go. Oh, but we need to change the slide.
Well aware of my location.
Can't be any worse than mine. I
said you're well aware of my limitations. Being both a physician and a male gives me a big disadvantage in getting stuff done. All right, so good afternoon. We're going to talk about developing partnerships with hospitals, academic institutions, and beyond that. I think since we're in LA, we should also talk about the concept of Hollywood of conscious uncoupling, because you're going to need to unwind some of these things. And how you do it can be good or bad, or do I push you? All right, so just a little bit about Borrego Health. We believe we're one of the largest teaching centers in the U.S. I don't really know that for sure because it's a matter of phone calls, but currently we have 180 residents rotating through our clinics, about 140 medical students, and about 40 PA and 40 nurse practitioner students, 120 nursing students, and 50 medical assistants and phlebotomy students. And you go, what are you guys doing? Sometimes I say that too. But what we're doing is trying to just create the right pipeline to staff our clinics and our partners and the community with all levels of physicians and other providers and staff. And if we don't become part of the solution, and that is collectively us, it's not going to happen in California. And when you look at the physician provider shortage that are continuously projected here, and I think you all feel this, if we don't become the solution, our whole business model gets kind of upside down quick. Low demand, high salaries, it's not going to work. We have the extra challenge of having clinics that are incredibly rural, so it's very hard to get people to go to some of our clinics that are way out in the north of the Salton Sea. So we have multiple models. I'm going to talk mostly about sponsoring institution, which we do. We are the continuity clinic for affiliated residencies, and we're site for specialty required and elective rotations for multiple programs. And before I go into this, I talked about this in our breakout groups, but before I started, our CEO, who was very generous and was a fire starter, gave all the faculty a 10% increase if they got a faculty, or all the physicians a 10% increase if they got a faculty appointment and taught somebody, which was actually great. Everybody was enthusiastic. However, it's not a focused strategy. It's I'm getting a 10% increase. I'm going to partner with them. I'm going to partner with them. I'm going to go for it. You get this. So that's what I walked into. We sorted that out. As a sponsoring institution, one of the first things that we did when I hit the ground is we got that, and he left the room. She was actually a very important part of that. And early on in the process, I was the only one driving this. So using a consultant made a lot of sense to get this off the ground. We had people internally, but as we got on, I started developing an infrastructure. We have a 3-year family medicine program that starts this June. We have 6 residents per year. We've already taken the first and second year class. We did it outside of the match. We went through ERAS. We went outside of the match. I cannot be a gambler. Our clinic is in San Jacinto, which is somewhere. It's south of Palm Springs and east of Riverside and north of Temecula, and someplace far away. It takes me an hour and 45 minutes to get to, and I drive out there. So I didn't feel like starting a new program in a very rural place was a good idea to take a chance of going into the match. And it was just a decision. Next year, I think we're going to reevaluate that, and we may do that. But and what we were able to recruit in our class was all inland Southern California physicians. 2 of them actually end up being Emmett, which is 3 miles from San Jacinto. So we are, doing exactly the pipeline that we wanted. We also have a site visit coming up next Monday for preventive medicine residency. We were very aggressive at 12 residents per year, and I can talk a little more offline about that. That is the only residency that doesn't require a hospital partner, which is why I started exploring this. And I'll talk a little bit more. We're the continuity clinic for lots of programs. So Eisenhower's Family Medicine program, we've been doing this since 2013. We have 2 faculty. We take 12 of the residents. Riverside Community Hospital started a family medicine residency in 2017. It'll be fully built as of this July. It'll have 24 residents. We are the primary continuity experience. The program director and 3 out of the 4 of the core faculty are Brago employees. The only other core faculty is a hospitalist. So we moved to exactly what Kiki was saying. We moved to try to figure out ways to get control of the program so that we weren't running around. So it's their program. There's limitations with RCH/Healthcare Corporation of America on things, but we actually are able to recruit residents that fit our mission, and I can't emphasize that enough. And we're not recruiting them to send them back to New Jersey or wherever. We're recruiting everybody with a Southern California focus in mind, or at least the California focus. This is under the category of conscious uncoupling. Riverside Community Hospital internal medicine program. We have 45 residents a year. We're going to use their continuity clinic for ours. We're decreasing our participation. As you ask yourself questions, this program, by the time I got my feet on the ground and we looked at a financial analysis, it was costing us $1.5 million a year to support this program. Not a good relationship, not a good long-term strategy. So we went back and, we had the hard conversation of, we need to get out of this. We have two options: pay us $100,000 a month, or we got to get out of it. And they go, well, we can't pay you anything. I go, well, then, but we don't want you to leave. I'm like, well, okay. So we'll be out of that in 2020, but we're down to 15 residents as of July. We'll probably break even. But this is, the reason I put this one up is it's really important because you really got to think about your space needs. This clinic went up for a simple reason. We had X amount of exam rooms, we had X amount of providers, and we brought 8 residents, gave them each 1 or 2 rooms, and our productive providers no longer had rooms to be productive. So things really turned out. And then the program requirements of supervision things, I really stick to the ACGM guidelines. Your hospital partners, particularly if they're sponsoring and the directors, may have different ideas, and I go, they're great ideas. Just write me a check and we'll do them. We're going to follow the guidelines. So, they wanted a precepting model of 1 attending to 2 residents. ACGM allows 1 to 4. I go, fine, we're going to do it. This is the cost. Do you want to do it? And they go, no, we don't want to take it. So, we made some changes after I got there. I put the University of California Riverside OB/GYN program on here, and I think I put it on as a caution. This program, we are the continuity clinic, and it's a partnership between UCR and Riverside Community Hospital, but they had their 2-year site, or 1.5-year site accreditation visit, and they were told that we're pulling the accreditation from this clinic. So what he just said about what does this look like unwinding a program, you really have to think about it, and you really have to follow the guidelines. And the more partners you have, the more opinions you're going to have in this. So you just really, really have to be careful, and you just have to follow the guidelines. There are some places where you can, go around the edges, but there's not a big edge here. And I think this is a good lesson to all of us here, is that programs do lose accreditation, and the impact on residents, the community, for us, the impact of losing an OB/GYN residency is part of our overall pipeline strategy for Inland. So they're currently appealing. That's a complicated process, but you don't ever want to be put in this position. The other thing Kiki alluded to, and maybe she'll talk about this a little longer, when we signed for our institutional accreditation, we also signed something that said we are financially responsible for these residents. And that gets really interesting if your funding is coming from your hospital partner. So I suspect this is a big, big mess between, the hospital and the university as who's actually responsible. Because I've heard the terms, funding follows the resident. Well, when you do something like this, you get orphaned residents. You're actually responsible for paying. Somebody's responsible for paying the remainder of their training. This is a $2 million hit, maybe $3 million hit for somebody here. Not us, though. It's the good news for me. We do elective required rotations as a regional, the internal medicine, neurology programs, Eisenhower Family Medicine, internal medicine. RCH, we do transitional neurology. University of California, their Palm Springs Family Medicine. We do electives and required for them. The reason I put this up is you got to really think about your strategy here. Is everything you're doing in line with what you want to accomplish? And again, we started that very quickly from the gate. So developing partnerships. You have to really think about what you're doing. And that whole thing, ask your why. Really ask yourself why you want to do this and what are the alternatives. Because as you know in life, anything you do has upside, potential downside. So there's inherent risk to you, your business model, your sanity. So understand why you're doing this. And I'll talk a little bit more about each of these. Develop an internal strategy and vision. evaluate your readiness to do this. That's where I think we have a lesson learned. That, again, we went into this full steam ahead. Part of it was my fault, some of it wasn't. That this started, and I was consciously uncoupling from the University of California, but the new dean wasn't there, and I couldn't leave. I couldn't leave the university until the new dean got there. Like, it would have been a disaster for the School of Medicine. So I ended up coming about 6 to 9 months later than I had planned. Had I been there on time, I could have stopped some of this, but I guess it makes my days more full. Develop your benefit to your partner. Know what your story is, what you're bringing to them, and what you're expecting of them. Understanding the financial impact to your hospital partner. And that might not seem intuitive because you're thinking, oh, the hospitals have lots of money. Not necessarily. And doing things with the residency, anytime the resident's not in their hospital or not in your clinic, they may not be getting funding if you're getting the funding through the hospital. So you really have to think about that. Find an academic and hospital partnership best aligned with your organization. And that is really, really important. And also, caution is that, just in life, that hospital administrations, academic institutions, leadership changes often. And you're often one hire or fire away from your reality changing dramatically, or the philosophy of your partner institution changing. So again, thinking through this, having this in writing helps. So the why. So why does any of us want to do this? And you have to develop your own why. You want to differentiate your organization from others. You want to create a pipeline. I think we all know that residents and students, generally elevate the quality of our clinics and our physicians and our systems, because they ask us questions all the time about why you're doing that. And you go, well, yeah, not really sure. So you gotta figure that out, because next month you got other people asking the same question. Medical education increases provider, physician retention and job satisfaction and recruitment. We did a probably non-scientific, but we roll out a Survey Monkey every year, and about 94% of our providers feel that education enhances their job. And they go and they complain about having learners, but at the end of the year, that's another aside. GME opens the doors for other business opportunities. Anytime you're in a partnership, you're going to find synergies, and you're going to find other things that make sense and that can benefit your organization. So I think there's lots of good whys. Internal strategy and vision. Really think about what programs you want, how many programs. Most of you are going to think about family medicine, or various combinations of affiliated. How big do you want the programs? What can you actually support? And that means with physicians that can teach, and space and staff time, and it really changes the flow of patients in your clinics and your operations people. And CFO get very nervous, particularly early on, because your residents, when you start this, aren't really productive. When you get these fully staffed up, the math generally works. But the first couple of years, it's like an ice bath for you and your staff. They just get shocked. What types of residents do you want to recruit? We only want Southern California /California students, or somebody with a very strong California connection that wants to practice in an FQHC, a rural area, or with our hospital partners. And we're going to stay true to that. We're not going to educate for the East Coast or other places. People may go, but we're going to try to stack the decks as best we can. Where do you want them to go? after residency? Do you want them to stay with you? Do you want them with partners? Or I don't assume anybody here is going to want to do what we do in academic medicine. Just have them go out and spread the gospel related to your university. All right, readiness. This is actually conversation. The CEO, the officers, the physicians, the staff, they all have to be involved in this process. And I guarantee you, no matter how much you have them involved, somebody's going to come back and say, I never heard this before in my life. But you're going to keep communicating. It's just, and I have that conversation every week. Somebody goes, I didn't know about that. I don't know how you could, but no, I kind of stay polite. Physicians, look at your physical structures so you don't make your model upside down. Think about, do you have a qualified DIO? Do you have a qualified program director? Is that person one and the same? Do you have somebody internally that you can elevate to, a residency coordinator? You're going to have to train them up if you do, unless they have some. Will you use consultants? How often will you use them? What will you use them for? You have physicians that are willing and capable clinician teachers. Because generally speaking, good clinicians are good teachers. However, it's not always true. You know who those people are. They come and you walk away and duck in the room because they're the ones that kind of needle you or jab you in the ribs. Do you have realistic timelines on when you want to start things? Financial impact. Think about, that may be a no. We don't either. So think about the impact on productivity, because as much as you're going to hear this model is really advantageous, it's really advantageous for hospitals, because when I built these in a private practice kind of model, it's usually about $1.5 million to start the residency, and figure you're going to lose, depending on the size of the residency, if you're not in the FQHC world, you're going to lose about $1 million, $1.5 million a year on a family medicine residency from billing these collections. We fortunately have the PPS rate, so it does help, but don't get lulled into thinking that is, the magic bullet here. You really have to look at productivity. You've got to map productivity models. You've got to map rooms. You got to think about residents getting pooled. You got to think about things of, are you going to have 2 people, 2 physicians tied up precepting 5 residents? Or are you going to have 1 to 4? Are you going to have 1 to 3? But all those little things keep adding up to your bottom line. You're going to need residency support staff. What's your funding model going to be? Are you going to try to do this out of clinical revenues? Probably isn't going to be your total answer. Are you going to look at grants to fund your residency? Or are you going to go, Kiki's talking more about this, are you going to go the traditional CMS, Medicare hospital funding pass-through? I kind of talked to you before. I'm not a gambler. I've actually gone with number 3. All right, benefits to partners. Who are your partners? Your patients, your community foundations, your schools, your community physicians, hospitals. Everybody's going to be a partner here, and you should start talking to them about that partnership. All right, financial impact. Some of your conversations to the hospital, particularly if they're not familiar with residents can be a new workforce for them. And they can get cost reduction for hospitals. In the old model, they used to have house stocks. Now we have hospitalists, but residents are actually a really cheap form of employees. They can work up to 60 hours a week, 80 hours a week. So you want to have those conversations. Some residencies are more important to hospitals than others. Internal medicine is a very good hospital for residency. For hospitals, family medicine, less so. And training is mostly ambulatory. And that goes with all specialists. Understand, again, your funding mechanism. Understand the costs outside the four walls of education and who's responsible. You're going to need internal rotation. You're going to want to do electives. There's lots of unanticipated costs until you get the program through. A poor understanding of the costs can be a huge risk in relationships, both external and internal to your organizations. So again, it's kind of like family finances. You know, there's, I guess it's one of the biggest stresses now on, or always been one of the biggest stresses on relationships, although I read something on my news feed that something else up, but I forgot what it was. Probably paying attention to your relationship. Academic partnerships. Do you want an academic affiliate? So there's some real benefits to this, and there's some real downside, because again, every conversation is different, and every partner is different. So universities offer expertise in education. They do this. This is their core competency, not our core. Universities like to extend their name, so they actually like to affiliate because they can write new grants and say, we now have residency programs, even though they're affiliated, you know, all over the state of California, and therefore, you know, we need to get more money for something. And they'll often go to legislature to do that. Can be powerful recruiting tools for residents. Having a university on that graduate's diploma is actually important, and you know, they hang it on their wall or they have it. Can be a great pipeline in the future, and you really need to look at the institutions who you already have a relationship with and how good are they. If they're bad now, they're going to be bad when you go further down the road. If they're good now, I think they're going to be good going down the road. What aligns with your institution? You know, who has the same philosophy? You know, you really have to get on the same page about what the goal of the residencies are. All right, so now you got to go out in the process. So the process is somewhere a combination between the show The Bachelor and speed dating. So I went out and I said, I want a family medicine residency. And then I went out and I started talking to all the hospitals, and this one had a closed cap, and this one had a change in leadership, and this one didn't want a second residency, and this one thought it was a good idea. And then eventually I found a hospital that wanted to get married. So we got married. But it is, it's a lot of conversation. And even getting into the institutions and to the right people, particularly if they're not a natural partner, is a lot of conversations to build up to get to that administrative suite that can make a decision. And then you also got to figure out in that world who makes the decision. Of course, the CEO makes the decision. Probably not. In a lot of hospital systems, the CFOs make the decision, particularly in the for-profit world. Doesn't mean that. And different for-profits have different structures. So usually one of those two people are the ones you got to get to, or both. I always go in and start a conversation about, we're thinking about a residency, or we're thinking about this. Tell me about your organization and tell me about your stress points. Because you'll start hearing what they're concerned about, and then you change your conversation around about how the residency program can actually help with their stress points. If their stress points are, we have an aging medical staff, which is everywhere. It's good. If there are expenses, I don't think we can do this because we're having financial issues. You say, well, this is a new funding source potentially for you, and this is a new workforce for you as a cost avoidance. So find those opportunities to extend the conversation, and don't think you're going to get this in one fight. It's going to be, over and over and over. Find those win-wins. There's some easy things that can happen that everybody feels good about and doesn't cost anybody money. Realize that compromise is part of the relationship. You're not getting everything you want. Your partner shouldn't be getting everything they want. And if you end up like that, you're going to have troubles. I think this is my last one. No, it's not. So it's a surprise when I do these in advance. But Natalie told me I needed to get this done before Friday. So relationships are complex. Some of our relationships are decreasing. They don't make sense. They don't make sense for our pipeline. They don't make sense financially. They don't make sense for the emotional toll that it takes on staff and programs. What are our priority partners? And we've actually tested the relationship of our hospital partners by actually asking them for stuff. Because, you know, I think in general, you know, we're just happy to take care of our patients and do things. And FQHCs, you know, although we have relationships with hospitals, we've stayed fiercely independent from them. So time's going to tell you, but asking your partners and reevaluating that relationship is a good thing. Because I've had people say no. And, you know, about the third no, you go, well, what am I doing this for? You know, I'm not asking for millions of dollars. I'm asking for something that may actually even be one of their programs to help actually enhance your program, not even my program. Look at your shared visions. Personalities and communications define the long-term relationships. There are some people that you're going to go in and you just go, I just love them, they're great. And there's other people and go, oh, God, I never see them again for the rest of my life. That's too soon. So I look at that and realize that administrations change, so your reality can change. So again, get things in writing. Key points: understand your why, over-communicate and plan, be clear on your goals and your readiness. Realize this is very different from most of our core competencies, expertise. So, you know, a new area here. Find the commonalities with all the stakeholders. You're going to have community partners. You're going to have foundations. You're going to have insurance companies. You know, take pride and celebrate the success and appreciate the journey here. That this is more of a marathon than a sprint. You might feel like you're sprinting. So once you get approval, there's these natural pauses, and then you're going to have adjustment periods. All right, this is my contact is easy to get a hold of me, and I think we're going to hold questions for that.
Oh, sure. Yeah, we'll do introductions while other members. So I know we kind of did it earlier, but my name's Erica. Like I said, I work at Ultimed. I've worked for 19 years. I used to oversee the operations of our medical group and moved into workforce issues because I complained enough about the fact that we never had enough quality people. And it wasn't really a part of our strategic planning. We talked about our people, but then when strategic planning came up, it's all about, you know, numbers and growth. And so an opportunity arose to be able to really take a look at our what we need for the right capability and capacity for our workforce in the future. I oversee our workforce development program, so we have pipeline programs from high school now all the way through residency training, and happy to be here and share a little bit about that.
So I just wanted to reintroduce myself as well. I'm Ismail. I serve as a designated institutional officer at Ultimed, and although I've been with Ultimed since October full-time, as a fellow, when I was going through training and health services, the CEO, Castulo, invited me to be part of the board, and so I was part of the advisory board, which is uncompensated position, and so I got to learn a lot about Ultimate. And then one day, jokingly, he said, well, when would you consider working for us? And I said, well, when you get serious about building a teaching health center. And so here I am. So don't ask for what, you don't.
We're not really serious.
But, it was sort of, I came from UC Davis, so I came from the academic side, and kind of finally decided to cut the umbilical cord. And I think that the growth of our focus on our patients, which really need preventative and primary care, was really what pushed me to leave the academic centers that often are thinking more short-sighted and training them to only be in hospitals. And so teaching health centers are a great model, and I'm really glad to hear many of you are also considering building out your teaching health centers. So a little bit about Ultimate and be brief. So we're many folks refer to us as the largest independent federally qualified health center in the U.S. We were founded as a free clinic in 1969. You can see our little shingle there, free clinic, dependent on volunteer physicians. And Gasulo, who is a lawyer by training, came from UC Berkeley as a as a way to have many projects, and was tasked with really volunteering his time at the clinic, but eventually figuring out a way to make it sustainable. And then, 40 plus years later, he's still our CEO, or became our CEO, and really evolved into a federally qualified health center. So over 300 physicians, 1,000 employees. Many of them reflect the communities we serve, which is about 80% Latino, lots of women in our workforce. Many identify as ethnic minorities. So we're serving about 300,000 patients. That's about 1 million annual visits, and about 40 we do AIDS centers, HIV-focused practices, and of course, primary care. And what we're going to talk to you about is focused care clinics. So largely underserved population we serve, and as we've had an opportunity to really think about, well, we're not just building a teaching health center, teaching and learning health center. We sort of wrapped our vision and mission as a medical education department around Ultimate's existing vision and mission, and that's to be the leading community-based teaching health center for current and future health professionals. We see our mission is to attract, develop, and retain students and health professionals who will eliminate health disparities in healthcare access and outcomes. And that's really through quality care and a huge focus on appropriateness of care, evidence-based practice. And that's really a big task for us, because we have to prepare our current workforce to really understand what that means, so that when our residents ask why we're doing that, we actually can support the evidence behind why we practice the way we practice. So it's been transformative. We're sort of now really, one of the key questions that we had a retreat just focused on medical education, and one of the key questions that our training officer said, what are we going to do to change the culture? Because that's really what it's going to take to bring learners here. And so luckily, Ultimate has invested heavily in bringing learners, which you see here in the center. And so it really started with high school getting their GED, but then also training, and then the high school population, but also the university and medical school students started rotating through our FQATs. And although not without a real true structure for training or education, I think many of our preceptors, if anything, again, feel really rewarded to have students. Opportunities are often, and it's really about matching the passion that folks have in education and supporting that passion. And I think that we were sort of, as we were sort of asking, doing sort of our listening tour, we were starting to hear, well, yes, this is starting to feel like you're just asking me to do one other extra thing for you. But really having now a program where we can support preceptor training, bringing university professors others to come and teach us again about what a preceptor. And that's been my clinical experience through rotation and accommodating up to White Memorial, which has been one of the hospitals where our patients attend. And it's also been through a relationship we've had with Dr. Hector Flores. And so he helped us build this rotation, which has served as our test model for whether we could do residency training or not. And so within the last 17 months, it's given us a lot of information as to where we're falling short and where we really need to step up our efforts in order to have learners who are residents. So one of the biggest complaints that the residents had when they came to this experience, they want to do more, right? They want to see their own patients. They want to be in the let's have them observe. We're not sure if they're going to sort of behavioral health and other services, but they were very clear to us, like if we're going to consider a huge task, how do we get them through EHR training, get them through and then so they can see their patients, and then we have to train the preceptors to sign off on those documents appropriately so we can get the billing and all that right. So it's a lot of, again, testing the waters with whether it's a rotation or setting up a small effort in terms of having residents come will help you understand their needs and inform your build-out. And then we see this obviously as an investment for us to ensure we have the right practitioners that want to come to Ultimate and stay at Ultimate. I think one of the saddest things is when we have turnover, so we have and they leave. That's a huge investment and a opportunity to also understand what our evolving practice needs are. And many of our practitioners also want to stay up to date. And how do we do that at Ultimate without having to depend on them going and getting their piecemeal everywhere else, right? So we were trying to build CME within Ultimate, given our medical education department's tasks. And so just to give you a little history, 2005, we saw an opportunity to provide our patients with specialized and hospital care at Children's Health Los Angeles. It's actually what started the partnership and discussion around, well, what are sort of the win-wins in terms of we have prospective payment, we can pay better rates for your practicing physician, and in exchange they get to practice in our clinic and take care of our kids and make sure that if they detect something, they can call the hospital, get the specialist early enough so that all our patients get quality care. And many years later, 90-plus residents are rotating to these clinics now. Many of them in America were a little bit more detailed, but really understanding the ultimate mission, committed to that mission. And now we have greater conversations with CHLA about what else can we do? Can we set up an ambulatory care residency training that's really focusing on getting pediatricians to really feel comfortable with outpatient care, not as much because most of it tends to be hospital care. And so now we have the rotation, 2018. Now we have physician leaders at the FQAT doing some teaching, really talking about the FQAT model. Now the 45 SM residents that you see there on the slide are coming from all over. So we have residents that come from UCLA, from USC, from the California Hospital Program, White Memorial, as far down. So multiple programs, and that gives us an opportunity to have our first encounter and see if there's a match. And we have actually interviewed a few residents who are considering coming to Ultimate from that just one-day FQHC day showcase. So there's different ways to showcase your FQHCs if you have the right partners. And then now we have our Department of Medical Education, so we're overseeing CME, GME, and UME. I'm really thinking about what it's going to take to build those programs out and be very creative in terms of our institute, which is a research institute, and how we support the scholarly work that many times, many of us are really, in the FQAT world, are afraid of in terms of like how so now we're using our other resources within our Ultimate as a way to study publish and disseminate throughout the state and country as well. So we did get accreditation, and we're on a speed timeline. We did get accreditation maybe a couple months ago from ACGME, and so right now we're finalizing our family medicine application that we'll be submitting soon. So I'm going to turn it over to Erica.
Okay, I'm going to talk a little bit about the partnership with DHA, but I wanted to mention, I did mention in my introduction, that I'm also a product of the pipeline. When I started at community centers 17 years ago, I was actually a resident with the Title 10 program. I was an intern, and I got into Ultimed, actually, and I never left. And so I'm sure that those of you around the room have similar folks in your organization. And I'm just curious, before I get into the CHLA, how many of you have pipeline programs of some sort, even if they're not residents? So not many. I just saw a couple hands back there. What I was going to say about that is that could be a really great place to start. It is really to examine what you have. Is it meeting your needs? Is there is it the right partnership? You can continue down your path with Annie. So the ultimate partnership with CHLA really had nothing to do with pipeline when we started it. It was really about Ultimed having a need for more coordinated care for our pediatric patients, particularly those with qualifying CCF conditions. And the hospital at CHLA losing a lot of money on their outpatient clinic and wanting to know if there was an opportunity for us to leverage our SQHC rate. Obviously, the benefit to us is access to wonderful high-quality services at the hospital. So that's how it began. We had a CHLA member on our board for several years before we formed this partnership. And then when we formed the partnership, we established a joint operating committee. And I think Dr. Hyde and Kiki spoke to this. Those partnerships are really complicated and messy. At the beginning, it's challenging figuring out the relationship, and it evolves. But for us, over these past 10 plus years, it's evolved into really joint oversight over the growing operations there. So we look at finances, we look at membership, we look at how we brand, we look at quality, utilization management, the residency, and patient satisfaction. We operate the general pediatric clinic that's located in the hospital. We also just opened a facility in collaboration with the hospital several miles away. We employ the staff, and we contract with the hospital for physician services. We have a dedicated nurse leader who her whole job is to manage the partnership and the relationship. And CHLA has a medical director on side who partners with her in a dyad model to manage the relationship. We currently have 93 residents and 36 attendings that goes through this facility. Because it's a continuity site, we really have no responsibility for managing the residency program, which is challenging, especially one of that size. So we get informed of new classes coming on, and we have to manage 130 residents offboarding of the graduating class. It's really challenging in terms of scheduling, patient assignment and appointment schedules, and we do participate in resident evaluations. Some of the challenges is space, that's come up again and again, and I can't underestimate that as a key consideration for your learners. Patient continuity and resident selection. When we look at it, and because we didn't enter the relationship as a pipeline, we really didn't have a seat at the table, and still don't, frankly, in terms of resident selection. And so the program itself tends to attract a lot of folks from out of state, and it's not necessarily aligned with our patient population in terms of culture and language. So now, that we're a little bit clearer and more knowledgeable about what we need, we're talking about kind of extending this relationship into an ambulatory focus track, and actually have a meeting tomorrow to start kind of negotiating what that means, and being involved in resident selection is going to be at the top of the list. I think the successes that we can do from this particular endeavor has been that the residents get to learn the FQH model in the hospital. And so that has been a great, it's great from a simplicity standpoint in terms of logistics and scheduling and that nature. It's really allowed us to expand access. When we opened the clinic as our own FQ in 2005, because it had been academic-oriented clinic, you know, they were open 8 to 4, Monday through Friday, they said, but really a little bit earlier on Fridays. There was no after-hours care. There was no urgent care. And we changed all of that together in partnership. And since we've been open in 2005, quadrupled the number of patients that we're seeing. And so obviously that's allowed for continued expansion and reinvestment in the partnership. We had nearly 400 residents trained through that clinic. Today we have 83 practicing attending throughout our 2 clinics with CHLA, but also our other clinics. And a little more than half of those are graduate of And as I mentioned, there's opportunities for expanding now, and we're looking into a community-based. Over the years, that the financial model is key. We've evolved to shared risk arrangements with them to manage the patient population. And so that's really allowed those organizations to have a win-win as well as skin in the game. I mentioned the joint operating committees. That's key, and really making sure that we've got buy-in from executives to maintain time for that relationship. It's not something that can be delegated. That's when things start to erode. Workforce planning. I think if I had to grade us, you know, I'd give us a pretty good score on the first 2. Opportunity for improvement in workforce planning, because we didn't enter into the arrangements as a pipeline. You know, you get what you set out to achieve, right? And so we really now have an opportunity to better understand each partner's needs and co-plan around recruitment and hiring needs. Make it home. So your biggest asset as a continuity clinic site is that you need to make that place home for residents that are spending, you know, 60% of their time in that location. So the learning experience has to be great. They need to form relationships. The staff have to understand that we're doing something different here, you know, and these are learners, and this is, and, you know, so they're here to learn. We don't know everything, and we figure it out together. So it's a little bit different, you know, and it's something I would encourage you, if you're thinking of going down this route, to kind of self-evaluate the culture of that particular office. What kind of environment? How would you feel if you were going in there as a learner? Fortunately, for us, you know, when we hired the operations manager for this office, I said, I want someone who knows the hospital environment. They can learn SQHC. They need to know and be aligned to our mission, but they need to understand hospitals and how to navigate amongst that bureaucracy, and really kind of understand the complexities and make it home. And I think that is something that we've been able to do well. And then negotiate participation in selection. I would not give us a really high grade there, but I think it's an opportunity as we move forward and looking at other expansion opportunities to be much clearer about what are we looking for, what are the types of applicants that we really want to attract. And it might seem simple. I'm going to try to go back for a sec. It might seem simple, but the simple act of looking at our organization's vision and mission statement and reimagining it in the context of being a learning and teaching organization was revolutionary for me. Because not only for our residency program and what we want to accomplish there, but that slide of all the programs that we were involved in, that mission and vision then became the litmus test to say, well, let's look at our other relationships and Are they helping us achieve the development and retention of students in health professions who will eliminate disparities in healthcare access? Maybe not. Some of our partners really have no curriculum that are about training people to work in communities. They're training people to work in hospital settings, right? And so it's a challenge. And so definitely another key learning is, to take that step of defining your goals and what your vision and mission are, your needs, really articulating that very well around the workforce, and really use that as your guiding light in terms of selecting and even reevaluating some of your longer-term partners. Great. And so I think we were your last presentation. I believe now we're going to open it up for Q&A. All right.